The COVID-19 pandemic has resulted in close to 97 million cases and over 1 million deaths in the United States alone. While the pandemic has touched every community in our country, it has brought the striking social, economic, and healthcare inequities across the nation to the forefront. Prior to the COVID-19 pandemic, people of color and other underserved groups already face long-standing disparities in health. The COVID-19 crisis stressed the healthcare system to the breaking point, exacerbating the underlying crisis in health and healthcare, elevating the urgent need for change. The vacuum that exists was spotlighted, highlighting the gaps in healthcare coverage, the healthcare deserts, the poor and sluggish communication with medical communities, the inaccessible healthcare facilities that Black and brown communities navigate every day. Simply put, we are in a healthcare crisis. Stepping in to bridge that gap between medical professionals and local communities were our trained community healthcare workers. Community healthcare workers are dedicated individuals who function along a continuum ranging from individual and community development, service delivery, and community empowerment. They are tasked with linking people to needed healthcare information and services. Community health workers work in all geographic settings, including rural, urban, and metropolitan areas. Although their roles vary depending on locale and cultural setting, they are most often found in underprivileged communities where people have limited resources, lack access to quality health care, the means to pay for health care, language barriers, or cultural nuances. In these communities, community health workers play an integral role in helping systems become more culturally appropriate and tailored to the people that the systems serve. Today, we're talking to our implementation partner, Center for Global Health Innovation, an organization that stepped into the midst of this COVID-19 crisis to deliver much needed care to the underserved resource communities during the pandemic. Dr. Stephanie D. Adams is Managing Director, Office of Health Equity and Crisis Coordination, Center for Global Health Innovation. Dr. Adams is here to tell us about CGHI and their work. Later, we'll be joined by some of our partners, Johns Hopkins, Emory University, Association of Immunization Managers, and the National Association of County and City Health Officials. We went on the road, visiting with the local and regional organizations that the Center for Global Health Innovation funded to fight the COVID-19 epidemic to hear their stories. I'm your host, Reverend Sheffield, and I'm here with Dr. Stephanie Adams, who will tell us more about the CGHI model and their community health workers strategy. We'll also be joined by some of our implementation partners whose participation makes this work possible.
Yes, thank you. The Center for Global Health Innovation's vision is to envision a world in which social determinants of health are improved, and we can all work together collaboratively around the globe to solve these issues facing our countries and our world's most vulnerable populations. The office that I lead, the Office of Health Equity and Crisis Coordination, was launched at the outset of the COVID-19 pandemic in March of 2020. At that time, we had no idea how COVID-19 would affect our communities, our country, our world. What was soon apparent was that the pandemic preferentially hit our nation's most vulnerable communities, our underserved, our under-resourced, our most vulnerable. Very soon after the onset of the pandemic in March of 2020, we learned right here in America how our most vulnerable communities, specifically African-American and Latino communities in both urban and rural areas, were affected.
Absolutely. We have benefited, been blessed to have that mutual benevolent response to a community you've already so aptly indicated is underserved. Well, at the heart of this model is community health workers, and there's a lot going on with respect to that, more recognition of the value that they have. But tell us how that success has been achieved using that model.
Absolutely. Well, what we were able to learn through interacting with community health workers and community organizations and local leaders is that the most important thing that you can do when working in communities is to listen first. And even more important is to be able to hire and work with community leaders, community influencers that have their ear to the ground, that understand where their communities are at that moment in time. It's not to impose our agenda on the community, but rather to help them get through whatever the current circumstances may be, and then grow with them and help them understand the best medical treatments and innovations that could eventually help solve some of the issues that they're facing.
Well, I think one of the reasons you're successful is because you kind of balance where you do this work, the rural South, Rio Grande, Detroit. You focus your efforts in these communities. Why did you choose these particular markets or locations to do this work?
Well, in the summer of 2021, it was rapidly realized that the very populations that were most affected at the early onset of the pandemic were also under-vaccinated at that time. And so a large national grassroots movement and mobilization occurred across the country with federal funding, with some local funding, a real unbelievable mobilization. There was so much energy within the communities themselves to try to make a difference and try to help and prevent any more suffering due to the pandemic. So through that, we formed an unprecedented coalition that you will see here today of national nonprofit organizations, local community organizations, faith leaders, even some of the top scientists in this country have worked with us on this project in order to coordinate these efforts in a national campaign. So we launched across 7 states in 13 communities, rural, urban, predominantly Black and Hispanic. As you have seen during this broadcast, our work looks different in each community. We allow the community health worker as the trusted source of information in those communities to dictate their work plans and create a customized role and work in their communities so that they can effectively reach their communities where they are at that moment in time. In just 3 months, we have been able to reach over 160,000 individuals through personal interactions. We have also reached over 350,000 more people through social media, radio interviews, television broadcasts about this project, and really worked to increase confidence in COVID-19 vaccination in all of these areas.
When talking about the plight of African Americans in the United States, too often the focus is predominantly on those who reside in urban areas and on the lack of resources in metropolitan and suburban communities. This limited focus ignores the plight of the 1 out of 5 Americans living in rural areas. Rural Southern Americans are struggling. Healthcare is an issue. Rural counties have fewer healthcare workers, specialists like cancer doctors, critical care units, emergency facilities, and transportation options. Residents are more likely to be uninsured and live further away from healthcare services. Focusing on communities where healthcare systems are hard to access or totally out of reach is Dr. Veronica Womack, Executive Director of the Georgia College and State University's Rural Studies Institute. Dr. Womack has spent nearly 20 years in higher education as a political scientist, rural research, and Black Belt region supporter. Focusing her work on the underdeveloped rural South, she has brought local to global attention to underserved communities. Dr. Womack constantly connects her academic research and coursework to several community university governmental initiatives in the Black Belt region of the American South. Through a program funded by CGHI, Dr. Womack and her colleagues are improving access to a coalition of churches, health clinics, and other anchor institutions in the rural South. This work hinges on community health workers who work tirelessly to build trust in their communities and convince residents to get the care they need to stay healthy and safe. She is joining us today to tell us more about the community health workers and who serve as a bridge for families who struggle to access quality health services. Welcome, Dr. Veronica Womack.
Thank you. Thank you so much. I'm really excited to be here to speak with you this afternoon.
Absolutely. And your reputation precedes you. You know, we work hard in Detroit, which is a predominantly Black community, you know, with all kinds of, health challenges, underserved populations as well. For example, where our clinic is located, there's no urgent care facilities. The closest hospital is 7 miles away. What are the comparisons between the challenges we face and what you face in the rural South?
Oh my goodness. Well, the average distance between rural community people and urgent care or emergency rooms in some cases could exceed 30 miles. And when you talk about not having access to healthcare, we also highlight other issues, right? So the lack of public transportation. So even if you need to go those 30 miles, do you have the transportation to be able to travel to the nearest hospital? So when we think about the lack of preventative care, any issue that's related to the lack of access to healthcare, you'll find in the Black Belt region in particular is what my focus is usually on. But throughout the South, throughout most rural communities in the country, there is a plethora of issues. I think COVID highlighted the issues in the rural South because as most people suggested that people use telehealth, for example, many rural communities were not able to participate because of the lack of broadband. So you have the lack of doctors, you have the lack of facilities, you have the lack of access to even telehealth in many of your rural communities. And
so I think it's,
if you have, and even if you have access to telehealth, do we have the literacy, the digital literacy to actually utilize it?
Yeah, I was going to say, in many ways, it's very similar. I mean, you're in a rural setting, but in the city of Detroit, 50% of our population is illiterate. Vast majority don't have access to broadband as well. And so in many ways, we're both serving kind of the same kind of folks who without our help probably wouldn't get help. Tell us some of the major challenges you've faced with respect to that and maybe how healthcare workers have helped.
Oh my goodness. The healthcare workers have been tremendous. And this particular opportunity with CGHI has provided us something that we've always wanted, which is the opportunity to identify people who had been working in the community all along and then give them the resources to be able to do the work that they want to do.
Hi, I'm Dan Solomon. I direct the Institute for Vaccine Safety at Johns Hopkins. We had two roles in this project. First, we led the training of community health workers. So bringing the expertise of our team together, we created several trainings for all of our community health workers. We gave them lots of information on the science around COVID vaccines and other vaccines and places to get more information. And we trained them on a framework we created called the Be Real framework. So be real, start by relate and talk to your community members. You are from that community, you know people from your community, and find a way to relate with them. Then engage them. Find common values that you have, common experiences you have, and then address whatever concerns they related to. So if they were worried about COVID or other vaccines, be sure to address it. But at the end of the day, leave the door open. So be real. Be connected to them as a community health worker and a part of the system that serves them. The second part we had is we expanded a website we had developed called Let's Talk Shots. And what it does is you answer a few questions up front, and it captures what vaccines you're interested in, what concerns you might have, and then what community you're from. And we went into these 13 communities and we captured real stories from real people, their experience with COVID-19, their family's experience, and then credible people from those community, ranging from the governor of West Virginia to local doctors and nurses that had been working in the pandemic. So when you go to this website, You hear from people from your community, and then you get the scientific answers to questions you have about vaccines. You know, the straight science, what we know, what we don't know, and what the recommendations are. So it's been a great project to be a part of. We've enjoyed being a part of it and have heard from our community health workers that they did really well in their communities, which is great.
I am Lori Davis, Real Talk co-host. With us today is Dr. Terrace King, CEO of the Lucan Group. Joining him is Dr. Bobby Baker, Lucan Group President. The Lucan Group uses trusted partnerships with the church and community-based organizations to implement community models that have a proven track record of success in capacity building, increasing quality of care, and lowering health inequities. As faith-based and wellness intermediaries, Dr. King and Dr. Baker work with healthcare entities to reduce costs, improve quality, and facilitate the integration of care within communities of color. Trust is a major barrier for the medical community when interacting with historically underserved populations. Dr. King, how does your organization, the Lucan Group, build and leverage trust to accomplish your mission?
First of all, thanks for having me. Thanks for having us. We appreciate it. So part of what the Lucan Group does is to work with trusted sources. And those trusted sources are often community-based churches, not just any church, but churches that focus on serving the community. So our selection process is to work with the churches to train as employees the congregations of those churches to reach out beyond the walls of the building to affect the lives of both the congregation and the communities in terms of improving their health. And the way we do that, very simply, is that from a scientific approach, we analyze the community, we know their challenges, and we utilize those who really have gravitas in that community to affect change and drive down cost for the healthcare system.
Dr. Baker, the Lucan Group is known for its use of faith-based models. Can you tell us about these models and what strategies you utilize to produce such great results?
Yes, we have a couple of models that we really have the data to show that are actually effective. The Memphis model is a model that partnered with more than 600 congregations that actually accomplished all the things that we talk about. Health, the health of the individual, the health of the community, and also affected the costs. Also, Dr. King's model in Baltimore in addressing the COVID inequities there, the model that he used, all were congregational based. They're based on the trust that congregations have in the community. They're based on pastors who are actually focused on certainly taking care of the people inside of the walls, but who are open to addressing the inequities of the community and really want to make a change in the health of our communities. So we have those two models that we both have been involved with that really promote the equities that are necessary to improve the health and the lives of individuals in our community.
Dr. King, can you tell us more about the work you're doing to make sure that healthcare workers are hardwired into the healthcare sector? I know, for example, that you're working with CGHI. Can you tell us a little bit more?
We have chosen congregations, pastors in the zip codes that we're working in. Those pastors have hired community health workers to be the on-the-ground representatives and to work in those communities, number one, that they live in. Number two, they're connected with. And number three, that the congregations that they are out of, they're serving their own people in those communities. The healthcare system itself, in terms of hardwiring it, we're looking at policy that will help us actually create funding to compensate community health workers. As Dr. King said, he's a former policy maker with the Center for Medicare and Medicaid. In making policy, he also made policy around funding. And so the funding, if it's set up through the Medicare, Medicaid Center, all of the other payers will follow. And so that's how we're working to actually, the model's already been proven. Now we have to connect them to the payers. These are your insurance companies, your Medicare, Medicaid. If we can figure out and have them connected to the paying source, then we can have the community health workers hardwired into the healthcare delivery system. As Dr. King says many times, following the money is the way you get that done.
Excellent. Thank you so much, Dr. King and Dr. Baker. We are grateful for the work that you do to support our communities and to support the community health care workers. Thank you again for joining us.
It has been said that there can be no public health until we achieve equity in access, information, and vital resources. I'm here today with Dr. Walter Orenstein and Dr. Robert Bryman from Emory University, whose efforts in expanding immunization coverage embodies this sentiment. Dr. Bryman is known for his work addressing health equity and leading infection disease programs in Kenya and Bangladesh. Dr. Orenstein is the former director of the U.S. immunization program at the CDC. It is clear that you are driven by your passion for the work, and we're going to now talk to you about telling us about getting more shots in arm. Dr. Bryman, how are you today, sir?
I am well, Reverend. Thanks for having us here.
Sure. What do we need to do to improve coverage or more coverage or whatever it is to ensure more equity with respect to vaccinations?
Yeah, and you know, thinking about COVID, since the start of this pandemic, it's been clear that those that are at disproportionate risk for bad outcomes from COVID are also less likely to get vaccinated. And what I've thought is important all along is make sure that everyone has the information, the right information they need to make the right decision, and that they have access. And, you know, everything has to be done. Some of the work you're doing ensures that people both have the information and the way to get vaccine in order to address that equity.
Yeah, so we're very pleased to work with you because there has to be some connection between research or the academy and what we actually do in terms of getting shots in the arm. So we're also pleased to have Dr. Orenstein with us, who's written a novel book on vaccinations. Why don't you hold that book up for us real quick, Doc, so people can see your book? All right, Plotkin's Vaccinations, right? Or vaccines.
Vaccines.
So, Dr.
Yes.
Orenstein, given that you've written this book, tell us about the work you have been doing as it relates to vaccinations.
My focus is to get people for whom vaccines are recommended actually vaccinated. Vaccines don't save lives. vaccinations save lives. And what we need to do is show how vigorous work is to assure vaccines are safe and effective in all population groups, and then that the benefits far, far outweigh the risks. And when you get vaccinated, not only you're helping yourself, you're helping your family, and you're helping your community. And we need all groups to do it to help all of us.
It's a powerful point. Vaccinations aren't effective unless people actually get them. Dr. Bryman, what have you seen has overcome some of the hesitancy of people in my community to get vaccinated? I mean, has that changed any?
I think it has changed. And part of it is addressing this epidemic we have right now of misinformation. You know, people have all sorts of ideas, are hearing all sorts of things from various sources, but it's really important to get the credible sources into into everyone's ears and on their computer screens and everywhere that they can learn. And I think over time, there's been improvements there to make sure people are hearing things that are factual and not, fictional.
Yeah, we call it trust the facts. And finally, Dr. Ornstein, you have the last word. Anything you want to add to encourage people to be vaccinated?
Yeah, I think it's very important that vaccines are very carefully tested before they are approved by the Food and Drug Administration. And then recommendations are made in full public view so people can see it. We need to remember that our immune systems function like an army. Their goal is to detect the invader and destroy it before it can cause disease. What a vaccine does is it gives that immune system practice so that it's ready. You would never send an army into battle without practice. This gives it practice, and it's good for all of us.
Yeah, I like that analogy. You kind of drafting the army to attack the vaccine and to attack the actual virus, and the vaccination helps you prepare your army for the battle ahead. Well, thank you, Dr. Bryman and Dr. Go ahead.
No, exactly. Yeah, exactly. It's again being able to detect it fast and destroy it before it can cause harm. The germ, that is.
Absolutely. Thank you, Dr. Bryman, Dr. Ornstein. We're grateful for the work both of you are doing and for Emory University and the passion you show for helping to create pathways to health equity. Thank you very much.
As you have seen during this broadcast, our work looks different in each community. We allow the community health worker as the trusted source of information in those communities to dictate their work plans. We need people that are passionate about this work to consider this as a career path. In addition, if you're involved in a community at your church, a special committee, or a community organization, think about this as one possible direction for you to pursue through your church, through your community organization, so that you can help your communities be healthier and safer in view of the emerging threats that we see.
I've always had some reluctancy about shots and vaccinations.
It is so important to know what is true or not.
We all have our own responsibility in taking care of ourselves. We're doing our part.
I'm your host, Reverend Sheffield, and I'm here with Dr. Stephanie Adams, who will tell us more about the CGHI model and their community health worker strategy. We'll also be joined by some of our implementation partners whose participation makes this work possible.
Well, in the summer of 2021, it was rapidly realized that the very populations that were most affected at the early onset of the pandemic were also under-vaccinated at that time. And so a large national grassroots movement and mobilization occurred across the country with federal funding, with some local funding, a real unbelievable mobilization. There was so much energy within the communities themselves to try to make a difference and try to help and prevent any more suffering due to the pandemic. So through that, we formed an unprecedented coalition that you will see here today of national nonprofit organizations, local community organizations.
I've always had some reluctancy about shots and vaccinations.
It is so important to know what is true or not.
We all have our own responsibility in taking care of ourselves. We're doing our part.
Thank you. And again, my name is Robin Mosen. At NACCHO, we know that the public health workers on the ground are the experts on their communities, and that is why we value their diverse experiences. Whether they're coming from a rural or an urban area, serve thousands or hundreds of people. Part of our role is to champion culturally competent communications and services. The COVID-19 pandemic only further highlighted the need for health systems to acknowledge diversity and to find ways to reach equity in communities. We do that in part by including all voices and consideration of different lived experiences in the conversation. I consider one of my key responsibilities to be listening to what is happening on the ground and to raise up the voices from local public health. Whether that be their challenges, their successes, innovative practices, or partnerships, we are interested in and value all of it at NACCHO. But we don't just listen. We want to give something back. And we refer to this process as bidirectional communication. We create a feedback loop to gather information from local health departments while also working to communicate national guidance and recommendations to make sure it's being understood and is in alignment with local needs. Through this project, we were able to amplify the experiences of local health departments by supporting dissemination of timely information related to COVID-19 vaccination, and by building connections with partners and community health workers. We were very excited to have a health equity coordinator and an experienced community health worker from a local public health department at our trainings for community health workers. They were able to share their lessons learned and stories from the field, as well as answer questions from the incoming outreach workers. We were also able to connect with health departments that were using local vaccination data in combination with their community health ambassador programs. With this, they were able to identify neighborhoods most in need of support from trusted messengers that were already embedded in those communities. Again, immunization is only one focus at NACCHO because we know that individuals do not exist in a vacuum. Rather, people and communities have many competing needs. They have different priorities and values, and that is why we strive to take a holistic approach in our initiatives. We address topics from chronic disease to climate change, and our staff works with local health agencies to promote national policies, develop resources, and strive towards health equity for all. If you're interested in volunteering in your community or learning more about how to support health efforts in your area, we encourage you to seek out your local health department for materials or opportunities that you may be able to use to build trust and vaccine confidence in your communities.
the pandemic has touched every community in our country, it has revealed striking social, economic, and healthcare inequities across the U.S., including individuals in communities such as the Rio Grande Valley. We are now joined by Melody Cisneros Milstead, Executive Director of Development Engagement with Urban Strategies, a social enterprise that equips resources and connects faith and community-based organizations that are engaged in community transformation to help families reach their fullest potential. The team worked in concert with trusted faith and community partners, key collaborators, and social innovators in the Rio Grande Valley to reimagine and reshape the trajectory of children and families dealing with the COVID crisis in their local under-resourced communities. She is here to tell us more about how their team of social innovators, a committed group of self-driven social innovators whose work is action-oriented, effective, and impact-driven. Melody, welcome to the program.
Thank you. Good to see you.
Good seeing you too. So tell us a little bit more about your organization, the VAT project model, and how you work to transform community organizers into community health workers.
So Urban Strategies has been in the Rio Grande Valley now for 5 years, and it's a hard to reach community, but we have a great network of faith and community organizations that have already gained the trust of sometimes these hard to reach populations. So it was actually our model for everything that we do in our community is to engage the community and the faith leaders who are already trusted among this population.
That's great. That's great. So in your travels and in your history with this organization, tell us a little bit more about the Latin American or the Latino-based, faith-based efforts in bringing faith-based organizations and the community together.
So we believe that the center of community for the Latino population is very much faith-oriented. And it is so much easier to bring things to that population through trusted faith leaders. So for instance, with the VAT program and COVID, it was so much more effective to train our faith leaders and our community leaders about the vaccine and about COVID, rather than trying to build trust. You know, this needed to be rolled out very quickly. And so the community already trusted the pastors, the faith leaders, the community leaders, and whatever we did to support them just reinforced that information that they were giving out.
I see. So Melody, people will be curious about the work of a community health worker. Can you tell us more about like a day in the life of a community health worker, and give us a couple of examples of some real winning experiences or successful experiences?
Well, I love to talk about our leaders, our faith leaders in particular. We got them together and we started giving them training and so much of our time was spent in training them about COVID. Some had never had a healthcare background. And so we had to start from scratch and just really build up their knowledge base. And then they incorporated what they already use to meet community needs and to serve the population, all of their ingenuity and idea and outside of the four walls of the church thinking that made these faith leaders so great and popular in their area. For instance, we had a church that he was a barber and a leader at one of the barber schools. And so for a back to school campaign, they offered free haircuts to all the students, and they were holding signs, free haircuts. And as they would come in, we had a county vaccination program available there, and information and just anything to get them into the building.
I see. Yeah. So was there at
I have
any
a few
point
more
in time?
ideas.
Okay. Well, just one quick question. Now I want you to come back to one of those great ideas or examples that you have. So
Okay.
have there been language barriers in terms of communication?
Oh, well, all of our community health workers who are our pastors, faith leaders, and community leaders are all Spanish speaking. We live in a
Great.
population, I believe it's 98% Hispanic and Spanish
Yes.
speakers.
Gotcha. Give us another successful example.
Well, I don't know if you know, but our area is the citrus capital. And so we have a lot of agricultural workers who work all day and toil during the day. And so our churches went out to the fields and brought the information and actually coaxed the county to come out and give vaccines while they were out in the fields. That was a unique approach. We've had them go to nursing homes and to daycares because those are the populations that we felt needed that extra education to bring in. And the last thing I'd say is that they opened the doors to the church. During service times, during weekday services, they opened their doors. So people who were comfortable coming into a church service were also, the vaccine was also available to them at that time.
Yes.
So it made it kind of a seamless happening for most people.
Great. That's excellent. And it seems that you love what you do.
I do. I love the area. We have a beautiful population, rich with culture, very family oriented. And I tell you, we celebrate everything, birthdays and weddings and quinceañeras and births. And it's a very fiesta oriented location. And I love being here.
Next, we'll hear from the Association of Immunization Managers. AIM is a national leader for immunization programs and policies. The ultimate goal for AIM is to establish a nation free of vaccine-preventable diseases. AIM leads a number of initiatives designed to raise awareness, and their latest, a multi-state effort, leverages partnerships to close the communication gap between public health and local communities.
Wonderful, thank you. So as I mentioned, my name is Caitlin Wells, and I'm the Chief Research and Development Officer for AIM. And we represent the leaders of the 64 state, local, and territorial immunization programs. Now, AIM members play a crucial role in the jurisdictions to help prevent communities from vaccine-preventable diseases. Simply put, they are the key to getting vaccine to arms, from ensuring providers in their communities have the vaccines they need, to leading large educational initiatives. They are the initiators and supporters of partnerships that strive to reach all communities. And how we were involved in this project, we were really thrilled to co-lead the VAT project. And really what we did is we facilitated partnerships to develop educational materials specific to each community. Now, how we did that, we took the time to meet with community stakeholders and immunization program managers. We had conversations to identify their trusted messengers and understand their concerns and what messages would resonate. Then we took all this information, developed customizable social media posts in English and Spanish. And then we worked to tailor and send over 300,000 postcards in specific low vaccination regions that relayed the similar messages as the social media post. And why did we do this? Well, no, our approach was unique because we developed our messaging from the ground up instead of top down. All the social media posts and postcards about upcoming events and vaccine education use messages and images that resonated with each specific community. Then we adapted these messages into resources for the regional and state level. Now, this is important because we know the symmetry of messaging is key. The more an individual hears the right messages by trusted messengers, the more likely that message will resonate. And AIM members were especially excited with this approach. Many implemented these community-led messages in their vaccine education as well. Our effort was continuous because we worked to refine these messages as the community needs changed. A lot of work, but I think it made a big difference.
Supporting Detroit's neighborhoods and city residents continue to fight the COVID-19 global pandemic has been critical in the collective effort for us to stay safe and slow the spread of COVID-19 in our community. The Detroit Association of Black Organizations, formed in 1949, is focused on uplifting, unifying, empowering the African-American community, and that meant for us providing access to testing and vaccinations. DABO is an integral part of the effort to create pathways to health equity in Detroit and in this nation. Joining us now is Ron Lockett, president of DABO, and of course, Kenyatta Snap, COO, both of whom hold executive positions in this organization, but also volunteer and spend time as community health workers. Welcome to the show, guys and girls.
Thank you.
Good evening, Reverend.
All right, Mr. Lockett, let's start with you. Give us a little bit brief history on DABO, but more importantly, talk about the role DABO has played in this community health worker engagement of COVID-19.
Okay, well, DABO is a confederation. It is a federation of 130 Black and non-Black organizations that are focused on building capacity within our community. For over 40 years, we've been working, equipping the community with skills for empowerment, skills for equity, and when COVID hit, we jumped right into action. Right on our parking lot on Grand River, we started testing with the help of Premier Quality Health Center and just took it by storm. I mean, we just literally were one of the few organizations that were out there touching people at that particular time, because people were very, very scared of this ailment. You know, they just had no idea what was going on with it. And as a result, we were able to turn things around. And on that same parking lot, we attacked the whole notion of a food desert within our community by providing daily food to everyone who approached us during this particular period. We take care of a lot of things in our particular area.
Yeah. So, Ms. Knapp, you're a community health worker. In fact, you do all of the gathering of data and work directly with the community health workers, and you're one yourself. Tell us about your experience of addressing vaccination hesitancy and how we've been successful at DABO, having vaccinated over 4,000 people since the 1st of April.
So from a organization standpoint, and in all things as a community health worker, we are the front line agents of change that work in the community, meeting residents where they eat, where they work, where they worship, and also being able to glean information where there's hesitancy, not just about COVID, but also about the health disparities that are plaguing our communities. We are able to make sure that we're touching those individuals and offering an alternative to the traditional hospitals, an alternative to the traditional clinics, alternative to traditional pharmacies. We really are the frontline agents of change that allow us to support reducing and minimizing the health disparities that are plaguing Brown and Black communities, particularly in underserved communities like we are situated inside of DABO in the 48204 area code, zip code.
And as one who supervises the two of you in the work you do, it's people like you who have such a broad swath of the community that you all engage in. Aaron, Truitt, working with veterans and others, just a great team. Ron, before we go, we've kind of grown. You talked about World Central Kitchen distribution being the first site to really do community testing in Detroit. Now we're moving even further to be able to train community health workers. You want to talk about that for a moment?
Yes, we're just on the precipice of an incredible partnership with St. Augustine University out of Raleigh, North Carolina, a HBCU. And And we're just so excited about that, because that will literally be right here in Detroit. You know, we will have a historically Black university right inside of Detroit, and DABO will be partnering with that organization. And it's just so exciting that we will give Detroiters the opportunity to even enhance whatever skills they may have in the health field. They can even take it to the next level and get credentialed and obtain degrees.
And what's powerful about that is we have our own clinic, Premier Quality Health Center, run by Isha Price, who's going to be on the broadcast, but is traveling, and a place where people can learn on the ground level how to engage in illness prevention and health promotion. Well, thank you both for the great work you're doing. We know this project's been extended to the end of April. We look forward to being able to make other folks healthier and preserve their lives and others. Thank you very much. Community health workers, who often are from low socioeconomic backgrounds, have been defined as any health worker carrying out functions related to healthcare delivery, trained in some way in the context of the intervention, and having no formal professional or paraprofessional certificate or degree in tertiary education. In addition, the World Health Organization has suggested that community health workers should be supported by the health system even when they are not a formal cadre. They are the first point of contact between health service clients and providers, linking communities to the health system. Community health workers deliver a wide range of promotion, preventive, and partly curative services, including maternal and child health, HIV care, and treatment of malaria. They are also in the unique position of being able to bring insights about community health to higher level health workers. Paying community health workers is needed to recognize the importance of this role as part of the healthcare system. It ensures fairness in terms of payment for meaningful work and substantial time investments in order to provide much needed income. In summation, disparities in health and healthcare for people of color and underserved groups are long-standing challenges. The COVID-19 pandemic has exacerbated these disparities and heightened the importance of addressing them. Health disparities are driven by underlying social and economic inequities that are rooted in racism. Addressing disparities is important not only from a social justice standpoint, but for improving our nation's overall health and economic prosperity. The federal government has identified equity as a priority and launched a range of initiatives to address disparities both in response to COVID-19 and more broadly. States, local communities, private organizations, and providers are also engaged in efforts to reduce health disparities. A broad range of efforts both within and beyond the healthcare system will be instrumental in advancing equity, including prioritizing equity across sectors, providing resources to support efforts to advance equity, increasing availability of data, supporting and building on existing community strengths and resources, establishing incentives, accountability, and oversight for equity, and finally recognizing and addressing racism as a root cause of these disparities. Thanks for joining us. We want you to stay informed and stay healthy. Thank you to our major sponsors, the Association of Immunization Managers, the Detroit Association of Black Organizations, Choose Healthy Life, and Deborah Frazier Howes. We also want to thank Urban Strategies, National Association of County and City Health Officials, Lucan Group, Rural Studies Institute at Georgia College, Emory University, and Johns Hopkins University. Special thanks to our professional production team, Lori Davis, producer and co-host, Gerald Smith, co-host, Reverend Horace Sheffield, co-host, and silent partners. Thank you very much.
The human race stands upon a precipice. The threats to our survival multiply every day as our tiny planet hurls through a vast, unknown universe. The time is now. The time for you is now. We need more of us focused on creating positive change if our species has any hope of survival. I'm calling on you to find your inspiration to take on some of our next big challenges.
I've always had some reluctancy about shots and vaccinations.
It is so important to know what is true or not.
We all have our own responsibility in taking care of ourselves. We're doing our part.